Hi, this is Jim Osborne. I'm the Chief Clinical Officer for Triad Healthcare Network, and today we're going to be looking at RAF 101. You're probably watching this course because of your recent addition to Triad Healthcare Network as a provider, and we appreciate your time in doing so. Or you may be looking at this as a review of your knowledge about risk adjustment factor coding. In any event, we hope you find it helpful and interesting as you prepare and do the proper things needed to help us with risk adjustment factor coding. The purpose of our presentation is to give all THN providers the same basic information about RAF. Risk adjustment factor coding and understanding how it works is a critical element to the success of Triad Healthcare Network and to the providers within the network. So today we'll be looking at what is RAF anyway? What is the impact of RAF? How does this all work, or as we like to joke, does the leg really grow back every January 1st? Then we'll give you a couple of examples of how to do this, and then finish with a slide on what you can do to help THN with RAF. Now, in order to understand what RAF means and why it even exists, you have to understand a little bit about Medicare Advantage plans. And Medicare Advantage plans are contracted plans by insurance companies and other entities which take risk from Medicare. Now, in order to understand Medicare Advantage plans, you also need to understand a little bit about Medicare. So let's look at what Medicare is. First of all, there's Part A. Part A for Medicare pays for inpatient facility-based usage and care. As always, and with everything, Medicare pays 80% of the allowable charges, and so they pay 80% of the allowable charges in Part A for hospitalization. Part B pays for physicians and other outpatient care, some medications, and some other outpatient care. And again, Medicare pays 80%. There's also one called Part D, and Part D is one that's probably most people are familiar with because this is the medication or drug benefit of Medicare. Most of the time, people buy a separate Part D plan, although it can be included in a Medicare Advantage plan, as you will see, because as it turns out, an MA plan, a Medicare Advantage plan, is actually Part C. So that's where the missing C was in A, B, C, and D. And if you really look at it, then Medicare Advantage plan will include Part A and Part B, and it might include Part D. So as we like to say, C equals A plus B plus or minus D. Now, as I just indicated, Medicare Advantage plans take risk, and so they are paid a per member per month by CMS for each plan member that they care for. And then the plan pays physicians for their care, pays hospitals for their care, and other entities for the care that's provided for the patient. And this creates the total cost of care for the patient that you can see there in the middle of this slide. Now, if the cost of care is less than the premium or the PMPM that CMS has paid the plan, then the plan makes money. But if the cost of care is greater than the CMS premium or PMPM, then the plan loses money. So there are two things that Medicare Advantage plans really like to concentrate on, and that is how to increase the PMPM or premium from CMS, and the other is to help control the total cost of care by making sure the right care is delivered in the right place at the right time. Now, as it turns out, the way to increase premium is to have proper risk adjustment factor coding occur for the patients that are under the plan, as well as reaching the top quality scores that a plan can get on their patients. And of course, the total cost of care, they use prior auth and other mechanisms to try to control that total cost of care. Now, as we've just indicated, Medicare Advantage plans take risk from CMS, but here's a problem. Not all patients are alike. So if there was no risk adjustment factor process, then what plans would want to do is enroll the healthiest patients they could get. So the solution to that is CMS does a risk adjustment on each patient. So literally every patient has a risk adjustment score or a risk adjustment factor. This risk adjustment factor is based on certain acute and chronic illnesses that are predicted to lead to a higher cost of care. The result is that the increased RAF, or the higher the RAF in a patient, then the higher the premium the plan is paid on behalf of the patient and to utilize in care of the patient. So why is this important to Triad Healthcare Network? We're not exactly a Medicare Advantage plan. Well, THN is a next generation ACO, and just like a Medicare Advantage plan, we take risk for Part A and Part B. THN also has risk contracts with Medicare Advantage plans, and in those contracts, we take full risk or shared risk and savings. And so we want to also be sure to control the cost of care by being sure that the right care is delivered at the right time and at the right place. And we also need to be sure that appropriate PMPM payments are made on behalf of these patients. So we want to also be sure that the patient's RAF is correct so that the premium will be correct so we can afford to take care of the patients properly. So what's the impact of RAF? Well, the RAF of the average Medicare patient is deemed to be 1.000. Now, this is not the average well or average young Medicare patient. This is the average patient, the average Medicare patient across the entire range of Medicare patients, from those who have no medical illnesses to those who have serious chronic medical disorders. And the premium of the average Medicare patient is $800. So if a patient has an increase in RAF of just 1%, from 1.000 to 1.010, the premium is increased to $808. Now, THN has 85,000 lives in risk or in shared savings contracts. So although an $8 increase per member per month doesn't sound like very much, 85,000 times 8 times 12 is $8.1 million. This is why RAF is important to THN. How does all this work then? Well, RAF is calculated based on the diagnosis codes that are submitted on a claim. Now this is really, really important. It is not calculated based on the diagnoses that are in the problem list in your medical record. It is not based on the medical problems listed in the past medical history or the past surgical history in your medical record, nor is it from the consultant or radiology reports that might exist in your medical record. The diagnoses that drive RAF scores are, first of all, documented in the medical record somewhere, and importantly, are on claims submitted to Medicare. And the real kicker in all this is that each diagnosis must be documented and submitted every single year. So there are 72,616 ICD-10 codes. That's kind of amazing, isn't it? 72,000 plus ICD-10 codes. Wow. So for 2020, 9,981 of those are said to risk adjust. That is to say that they are deemed by actuaries to be conditions that are likely to predict increasing cost in the coming months and years. And these 9,900 or so codes are divided into 86 hierarchical condition categories, or HCCs. And that's a term you'll hear from time to time, HCCs. So all of these codes are divided into that. Now, generally, it is the case that high-risk conditions risk adjust, but not always. Some of it doesn't seem to always make sense. For instance, coronary artery disease does not risk adjust. But if you have coronary artery disease with angina, it does risk adjust. Even if that angina is being controlled with medications and the patient really doesn't have any right now, they're still considered to have coronary artery disease with angina. Now, after their stent or after their bypass surgery, if their angina is gone, then it's gone. Carotid artery disease does not risk adjust, but hemiparesis as a result of a stroke does. And osteoporosis does not risk adjust, but some fragility fractures do risk adjust, notably hip fractures and vertebral fractures. Then, Medicare takes a demographic coefficient, which takes into account the patient's age, their gender, whether they're disabled, or whether they're dual eligible. That means they're eligible for both Medicare and Medicaid. And that's one number that the patient gets. Then the disease A coefficient, that is the HCC score, if you will, of the disease A is added to that, and the coefficient or HCC score for disease B and disease C, whatever they have, and you get a total HCC score for each patient. And then all the HCC scores are collected and they are rebased so that the scores average will be 1.000. And then new RAF scores are published, and that cycle occurs twice a year. Again, I've said that the claims or the codes that risk adjust are those that are on the claim. But it's also important that within the medical record documentation that there is adequate documentation to support that the patient has that condition. And in this case, documentation has a somewhat special meaning because for most providers, we would consider something documented if it was simply in the medical record. And that might not be quite enough in this case. And it likely isn't quite enough. So there's two ways to look at this. The first way is to say that you need something in the top of the visit note, say something in the HPI about the patient's condition or in their past medical and surgical history or in the review of systems or even in the exam. And then you need something in the bottom of the visit note, somewhere in the assessment or plan where you talk about the problem. Now, another way to look at this is to say that there must be evidence that the problem has been either managed, evaluated, assessed, or treated. And that comes up with the acronym MEET. So documentation, again, is something that has specific meaning. And when charts are reviewed by auditors, they're going to be looking to see that you addressed somehow the problem that you're coding for, that you're putting in on the claim as a diagnosis. So again, I like to think of it as something in the top of the note and something in the bottom of the note that reflects that you've managed, evaluated, assessed, or treated the condition. Now, for some problems, this could be as simple as saying this problem is stable and there's nothing going on. Or it could be as simple as saying this problem is managed by another physician. Those are all adequate documentations for things that you aren't really having to intervene on at that point, but at least it shows that you've assessed it. And most importantly, this has to be done every year. Remarkably enough, if the code is not submitted at least once a year, then Medicare assumes that it got better. Now, this does lead to some real crazy stuff. For instance, a below-knee amputation is a risk-adjusting code because patients with below-knee amputations have higher overall healthcare costs. But if they're healthy and doing well with that below-knee amputation, it's not something that we necessarily think to address in the course of our care during a year. But if we don't address it 1 year, document it, and submit it on a claim, then from Medicare's point of view, the foot grew back. And of course, we know that's silly, but that's just how the system works. They are going to look every year at the patient's codes that are submitted for that year to assess the patient's risk adjustment factor. Now, with that background, let's look at a couple of specific codes and specific diseases and just understand a little bit more about how this works. So let's look at diabetes mellitus. Of course, you know that diabetes mellitus leads to morbidity, mortality, and higher healthcare costs. And while the diagnosis of diabetes is usually documented, the severity of the diabetes is often not documented. So, diabetes without complications, ICD-10 code E11.69. This has a RAF value of 0.105. But diabetes with complications, which in the case of a regular type 2 diabetic is going to be E11, is going to be followed by either 2 or 3 other digits besides 69. And remarkably, the RAF value for these codes is 0.302. Now, a wrong diagnosis then, if the patient actually has complications, say nephropathy or neuropathy or retinopathy, a wrong diagnosis leads to a loss of almost $1,900 a year for that patient with diabetes. And if we miss that diagnosis in 5,000 patients, and I know that sounds like a lot, but we have a whole lot of people in our 85,000 Medicare and Medicare Advantage patients who have diabetes. If we miss that diagnosis in 5,000 patients, it leads to a loss of $9.4 million. Now, there are many common complications of diabetes. Chronic kidney disease, retinopathy, and neuropathy are the classic ones. And these are known as the with complications. You don't really have to state that they're linked. They auto-link, and the complication is actually listed in the descriptor of the code. Here's some of the most common examples. So diabetes mellitus with neuropathy, E11.40. You don't have to state that you think the neuropathy is from the diabetes. It's assumed to be from the diabetes, or at least to be made worse by the diabetes. Diabetes with nephropathy, foot ulcer, chronic kidney disease, diabetic cataract, periodontal disease, peripheral vascular disease, diabetic dermatitis. These are all codes where if you put that code in, that you are automatically linking the diabetes with the specific complication. Now, sometimes it's helpful to be sure to code for the complication itself. For instance, chronic kidney disease, stage 3, stage 4, stage 5, and end-stage renal disease all have separate, all fall into separate HCCs and cause different risk adjustment factors to be added to the patient's risk adjustment factor total. So be sure to capture that. Foot ulcers, similarly. Neuropathy as well. So be sure to capture these other codes for the complications, because we may get additional RAF scoring as well. As it turns out, there are many other conditions that can be complications of diabetes. These fall under the diabetes with other complications, or E11.69. And in this case, you have to actually state that the two conditions are linked. So if you had a patient with diabetes who, say, had dyslipidemia, which probably is most of them, then you could simply type in, or you could put into your assessment and plan E11.69, and then you would also need to put in the ICD-10 code for dyslipidemia or hyperlipidemia. And when you do that, you are showing that these two conditions are linked. Now, you need to say something in the assessment of either the diabetes or the dyslipidemia that you believe that these two are related to each other. Now, the linkage could be causation. And we all know that people with diabetes, particularly if it's poorly controlled, are more apt to have lipid disorders. But it also could be that they increase the risk of each other. For example, sleep apnea has cardiovascular risk, diabetes has cardiovascular risk, so they add to each other. Similarly for hypertension. Hypertension has cardiovascular risk, diabetes has cardiovascular risk, and the combination has even more. So while they might not cause one another, they increase the risk of each other for the patient's health. And so that's a really important reason to be sure to capture the E11.69 when patients have these other codes. And it turns out that in reality, E11.9, diabetes without complications, should probably rarely actually be coded. Most patients are going to have either one of the with complications or one of the other complications with diabetes. And you just have to remember how to code them both correctly. Another example that I'd like to run through real quick is morbid obesity. Morbid obesity leads to morbidity, mortality, and higher healthcare costs, and it's increasing in frequency. It was about 5.7% of the population in the United States in 2007, up to 7.7% in 2016. Some experts predict it could be as high as 25% in 2030. Yet it's been poorly documented and attended to by many clinicians. In a 2018 study, only 55% of obese patients had actually been told they were obese by their medical providers. Now, the ICD-10 code for morbid obesity is E66.01, and the RAF value is 0.25. And if this diagnosis is present or absent, means a gain or loss of $2,400 in premium or revenue annually per patient. So if 8% of our patients are morbidly obese and we document and diagnose only 50% of them, we are losing out on about $8.2 million. As I'm sure you all know, there are actually two definitions of morbid obesity. If the patient has a body mass index of greater or equal to 40.0, they automatically have morbid obesity. And if they have a body mass index of 35.0 to 35.9 with two comorbidities, then you can define that they have morbid obesity. What are those comorbid conditions? Well, there's a wide variety of them. Several cancers are thought to be related to obesity. Endocrine neoplasms, breast neoplasms, colon, the cardiovascular disease and cerebrovascular disease are the classic ones that you might expect. COPD, diabetes, fatty liver disease, gallbladder disease, even gout. Obstructive sleep apnea again, peripheral vascular disease. You can see that the list of potential comorbid conditions is quite large for the morbid obesity. So in this case, you would put in the code for the morbid obesity, and you would also put in the codes for the other two conditions. And then you would have to say somewhere in the HPI, in the past medical history, or in your assessment or plan that you think these things are related. For instance, you believe that the patient's obstructive sleep apnea and hypertension are being made worse by their morbid obesity. Something like that will be more than enough documentation to support the diagnosis of morbid obesity. So I've tried to give you an overview of risk adjustment factor coding. I wanted you to understand a little bit about why it exists and a little bit about how it works. And then we've looked at some examples. So what can you do to help THN with risk adjustment factor coding? Well, the first is to understand that it's your responsibility to document diagnoses and build diagnosis codes correctly. The success of our network literally depends on you. For our primary care physicians, we would recommend that you consider an annual visit with each patient where you try to capture all the risk adjusting codes that you might not miss during their ongoing chronic care or even during your acute care visits. And respond to queries and information provided by THN as we monitor and try to help you do better. For our specialists, we would ask that you know what diagnosis codes in your specialty risk adjust and use them regularly. If we're all successful at this, then THN will be very successful. We've already shown that. We've been successful so far through our history, but we can do better. And we need your help. And as we do better, we will have the resources we need to take care of our patients and the resources we need to give providers incentives for the fine work that they're doing in our network. So I really appreciate you taking the time to listen to this brief audio PowerPoint. If you have any questions, please contact Triad Healthcare Network, and you can do that through your practice performance specialist who's in regular contact with your practice administrator. Thank you very much and have a great day.